And it really is a pleasure to present here today as part of the Mammy Network. So the slight disclaimer is that I am a neonatologist. And so thinking about kangaroo mother care and when to use it and the evidence behind it, I will mostly be focusing on neonates. That is the lens through which I've been viewing things. But to say that a lot of what I'm going to share with you today, it's very applicable in different settings with different ages, and we'll talk about some of the other evidence for use of kangaroo mother care. So thank you so much. Okay, so brief overview of the talk. I'll just give an overview of kangaroo mother care, what it is, what the definitions are. We'll think a bit about the mechanisms underpinning kangaroo mother care, some of the evidence, and there's been a lot of recent evidence updates in the last couple of years. And then importantly, practical considerations about how to deliver quality KMC. And hopefully we'll have lots of time at the end for some discussion. I'm sure you've got experiences of your own with kangaroo mother care and thinking about how this can be relevant for infants between 1 and 6 months with malnutrition. So it's important to say first off that kangaroo mother care is a package of care. A lot of people equate it just with the prolonged skin-to-skin contact, but it really is a package of care, and this was described by Sharpak et al. In 1997, which was one of the first randomized controlled trials of KMC. So you have the prolonged skin-to-skin contact between the naked baby, apart from a nappy, and the mum's skin. And that is a really key component, but it's not the only part. You then have exclusive breast milk feeding, early hospital discharge, and adequate support and follow-up. And you can see in this diagram here that different papers and groups characterize it in different ways, but you always have these 3 components. You have the kangaroo position, the kangaroo nutrition, and the kangaroo discharge and follow-up. And some people refer to KMC as, quite a simple natural intervention. So after studying KMC for several years and doing my PhD thesis on it, I've come to the conclusion that it's really quite a complex intervention because you're relying not only on the baby and the mother, but also the staff, if you're in a healthcare facility, and the family and the wider community and society all to buy into kangaroo mother care. So actually achieving this package of care in reality can be challenging, and we'll talk later on about some essential things you have to consider if you want to provide KMC. And also just a slight note, I've been at conferences where we spent a whole day discussing the correct terminology for KMC. Kangaroo care, kangaroo method, kangaroo family care, all these different acronyms, skin to skin. For me, I'll be referring to kangaroo mother care because the mother really is integral because of the breast milk feeding component of the package. So thinking a little bit about how kangaroo mother care works is really important. And so this slide is quite busy, but I think it is important to understand how interlinked the mechanisms can be with KMC. So if you look at the bottom, you've got the components, the position, the nutrition, and the support. So from the kangaroo position and having that skin-to-skin contact, what is actually happening to that baby is you're having release of oxytocin. And that is a key neuroendocrine mechanism. Now, oxytocin, as I'm sure many of you know, it has multi-system effects on both baby and mother. So a lot of the protective mechanisms from KMC come from this oxytocin. And you only get that when the skin is touching the skin. So in the baby, the oxytocin, it contributes to thermal control through skin vasodilation. And then the oxytocin in the mother also causes vasodilation. So the thermal control benefits are directly mediated through oxytocin. You also have better cardiorespiratory stability, again through oxytocin release, because that is stimulating the vagal nerve, which acts against the kind of flight or fight response that you get with the sympathetic nervous system. So oxytocin calms the heart rate, stabilizes the breathing, and results in higher oxygen saturation levels, and really regulates that autonomic nervous system. In the kangaroo mother care literature, you read a lot about zero separation, trying to reduce this separation stress. So every time you take a neonate or a small infant away from a protective, supportive environment, you take them away from the mother, you put them in an incubator, you have a cortisol response. And we know that cortisol stimulates, it's part of the hypothalamic pituitary adrenal axis. It stimulates your heart rate to go faster. It stimulates your brain in negative ways. And it is very poor for neurodevelopment. But by having the baby in skin-to-skin position, and there's a lot of evidence around this, babies have lower salivary cortisol levels and lower hair cortisol levels, meaning that the stress response is reduced. Really important when we're thinking about nutrition and feeding, this oxytocin stimulates specific enzymes to be secreted in the neonate's gut, which then promote digestion of milk. And in the mum, the oxytocin is directly stimulating breast milk production. So I really can't overstate how important this skin-to-skin contact oxytocin release is. Also within the nutrition aspect, the exclusive breast milk feeding, incredibly important. I don't need to tell you in detail about this, not only for the immunity aspects, but also for the microbiome in the gut and stabilizing that for small babies. And an essential part of kangaroo mother care is around empowering the KMC providers. So through education, really giving mothers that power and that autonomy over their baby and fully including them in the hospital care of their baby is very, very important in terms of detecting when these babies become unwell and maintaining safety within a hospital setting. So we know from research from over 40 years worth of research that kangaroo mother care has multiple benefits for babies, for mothers, and for health systems. So there's been several Cochrane systematic reviews. Really, I think the first one was in 2003. The most recent one was 2016, which is a little bit outdated now, and I'll tell you about a more recent systematic review, which wasn't Cochrane, but really showing that it's got mortality effect. And the 2016 review was the first one showing that it actually reduces mortality, reduces infections, significant reduction in hypothermia, and encourages exclusive breastfeeding. But what this review identified was you only see the mortality effect when you deliver 18 to 20 hours per day of continuous KMC for stable babies. And this is what the WHO used as recommendations in 2015, that KMC should be given to all stable babies under 2 kilos. So as well as the neonatal benefits, there's lots of benefits for mothers, including improved mental health, better bonding, there's less postnatal anxiety and depression. And that seems to be across cultural borders as well. And for health system benefits, reduced duration of stay because you're sending these babies home a lot sooner than you would otherwise, a more efficient use of resources, both human resources and incubators, which can be in short supply in low resource neonatal units. And just to mention that KMC is one of those interventions that began in the global south. It was developed in Colombia in the late 1970s, and now it is truly global. On the neonatal unit I work on in Scotland, we use kangaroo mother care. We call it something different, just skin-to-skin contact. But again, it's an essential part of looking after preterm and low birth weight babies. So really, since 2021, there's been significant new evidence for kangaroo mother care that has really caused a paradigm shift in how we think about it and what the global policy is. So this is the IKMC trial, which I'll tell you about. Also the EKMC trial, which was a trial that I led in Gambia from 2017 to 2020. And then there's another trial from Uganda called Omwana, which is just about to be published. So just to tell you a bit about the trial, that this was my PhD work. So we conducted a single center RCT in the Gambia, looking to see if you start kangaroo mother care early, within the first 24 hours of hospital admission, does that reduce mortality compared to starting it later? So we recruited 279 babies within 24 hours of age, under 2 kilos, and they had to be mild or moderately unstable, meaning they were on oxygen, they were on IV fluids, they were in respiratory distress. These were unwell babies. And the rationale being that, as opposed to looking after them on a radiant heater, which are often overcrowded, or in an incubator, which frequently didn't work, having them in KMC position would help to stabilize, prevent hypothermia, and prevent infections, and then result in better mortality. So what we found, we actually didn't find any evidence for effect. This was primarily because before we implemented the trial, the mortality rate for these babies under 2 kilos was 48%. Huge mortality rates, and purely by implementing kangaroo mother care as standard care, because it didn't exist before, and having research personnel, standardized management protocols to try and manage these babies, you can see here that the mortality rate in the control arm was 24%. So just by implementing recommended WHO care, we halved mortality. So then we didn't have power for the primary outcome. Importantly, we weren't quite able to deliver 8 hours per day. And I'll tell you that that is the magic number. Babies need to have 8 hours per day of skin-to-skin contact to have a mortality effect. Now, one of our secondary outcomes was weight gain at 28 days, which we measured as grams per day. So we were adequately powered for this secondary outcome with a power of over 80%. And we did not find a significant difference in weight gain. But again, I'll talk a little bit about why I think that was. And again, it's to do with the duration of skin-to-skin contact that you're actually delivering. So the IKMC trial, this was WHO multi-center RCT in India, Ghana, Nigeria, Tanzania, and Malawi. Recruited 3,000 babies between 1 and 1.8 kilo who were unstable, some of them on CPAP, some of them ventilated, so really needing quite intensive hospital support. And they began kangaroo mother care within an hour after delivery, which is pretty incredible. And they managed to deliver 16 to 17 hours per day. So actually, this is an amazing trial. And it was stopped early by the DSMB because they found a mortality reduction of 25%, which for a public health intervention is huge. Now you can see here on this picture, this was the setup that they had. This was the Indian site. So they had their mothers constantly present on a specially designed and built mother neonatal intensive care unit. They had a radiant heater per baby. They have monitors, continuous monitors. We didn't have continuous monitors in the EKMC trial. They had radiant warmers that worked, piped oxygen, fluid pumps for IV fluids, all of these kind of high-tech neonatal equipment. And that was very different to the context in some of the African sites. So they found in the IKMC trial, a greatest effect size was found in India. And on the subgroup analysis, the effect sizes in the African sites was less convincing. I think really reflecting that it's the package of care around the kangaroo mother care as well, which is really improving mortality. So in 2023, there was a new systematic review which was published looking at kangaroo mother care for babies. 31 RCTs, over 15,000 participants. So this is probably the highest quality, most rigorous evidence for KMC effect. Identified, compared to incubator care, 32% reduction in mortality. And on subgroup meta-analyses, this was seen across all gestational ages, across all weights, and across all ages at starting. The mortality effect was seen for giving KMC in hospital and the community, but only if 8 hours or more per day was provided of skin-to-skin contact. And this is where the magic number of 8 comes from. Prior to this is really the first evidence of what is the minimum duration of skin-to-skin you need to give for benefit. Also identified 15% reduction in infections and really significant reduction in hypothermia. Interestingly, they weren't able to generate much, any relative effect estimate for weight gain at latest follow-up. Okay, so in response to this new systematic review, the WHO updated their guidelines for management of small neonates, meaning birth to 28 days. And they now recommend kangaroo mother care, for all preterm and low birth weight babies less than 2.5 kilos. We know often babies may not have an accurate gestational age, so under 2.5 kilos is the cutoff, which is currently recommended by WHO. And it should be used in a health facility or at home for minimum 8 hours per day, starting as soon as possible after birth. They also recommend that KMC should be provided by the mother if possible, and we'll talk again a bit about that. And they specifically state that if a baby needs intensive care, they should be managed in special units where the KMC provider can be present for 24 hours to really try and get that duration up. And just thinking in terms of babies who are maybe born 32 weeks, they go home, they've been doing kangaroo mother care, their weight gain is faltering, and then they come back to hospital, maybe at 2 months of age, and they are under 2.5 kilos. This guideline doesn't specifically mention those babies, but I think you should really strongly be considering providing kangaroo mother care for that group of babies. And the guidelines also state that if you're transporting babies between facilities who meet these criteria, then they should be transferred in kangaroo mother care position. So what is the evidence for KMC and growth for neonates? So as I mentioned on the most recent WHO guidelines, they do have a really nice kind of summary of the evidence. They stated there was low certainty evidence from 11 trials of just over 1,000 participants, suggesting an increase in weight gain at 28 days. And they found a mean difference of 4 grams, which isn't a huge difference. In terms of early versus late KMC, really our trial from the Gambia was the only trial included in that. But I think a major limitation is we weren't able to provide over 8 hours per day. There was a systematic review published by Natalie Charpak, I think in about 2022, looking at all of the weight studies with kangaroo mother care. Clearly showed that actually there is a duration effect, a dose-dependent effect for growth. So on this forest plot, you can see overall with continuous KMC, it does promote weight gain, but the longer you provide it for, the greater the effect size and the more the 95% confidence intervals are supporting the effect size. So for weight gain, it seems that 6 hours per day is the magic number. Okay. So we've thought a bit about the evidence for kangaroo mother care, predominantly from neonates, but hopefully you can be seeing how that, could be applicable to some small babies who are slightly out with the neonatal period. So let's think about some of the practical considerations about how you actually provide kangaroo mother care to our patients. So when to start KMC? So I think it should be quite clear from the evidence that it should be started for babies under 2.5 kilos, really in any setting, hospital, at home, when the baby's being transported between the primary health centre and the secondary health centre, as soon as possible after birth, for stable and unstable babies, regardless of age. And the WHO small newborn guidelines don't state a specific age in which you can or cannot use kangaroo mother care. It is recommended not to use kangaroo mother care in babies who are critically unwell. So if they are in cardiovascular shock or they're needing recurrent resuscitation because they're having apneas, then you physically can't be doing kangaroo mother care while you're also trying to look after the baby in other ways. If they have something, some kind of abnormality on their abdomen, for example, a congenital malformation like omphalocele, or their umbilicus is infected, or in some higher center units, we often put central access into their umbilicus, then you don't want to be having that baby in kangaroo position. If the KMC provider has a skin infection, or if they are not willing or not well enough to be providing continuous kangaroo mother care, this isn't just something that the baby has to be considered around. Really considering the mother, her health, her mental health status is really important. Certainly in the Gambia, when we were implementing kangaroo mother care before the trial, there was really only a couple of instances when we unfortunately lost babies in kangaroo mother care position. It happens very rarely, but it does happen. And in both those instances, the mother was either not in a good mental state, or she also had some kind of illness, which meant that she wasn't able to be as vigilant to her baby as you would expect. And then when babies become when they get bigger than 2.5 kilos, they tend to not tolerate kangaroo mother care. You can see they get very wriggly, they just cry a lot when they're in kangaroo mother care position. And so experienced nurses understand that, and they're able to impart that information to mothers that when your baby starts doing this, it means they've now outgrown kangaroo mother care and they should be looked after in the usual way. You know, culture in the Gambia, culturally, it was on the backs of the mothers. I'm sure it is in many different countries. So putting a baby into KMC position, there is a very specific position you need to put them in. So they go between the mother's breasts in a frog leg position. So their legs are flexed, their arms are flexed, and you want as much of the baby's skin to be touching the mum as possible. It's recommended to wear a hat to help them with thermal control. And importantly, the head needs to be looking to the side. That's really important because you need to make sure their airway is not being obstructed. So babies have really big heads. It's easy for them to flex down. And when they flex their head, they can obstruct their airway. So it's really important to use a wrapper. And the wrapper, what you're trying to do is really secure the baby to the mother. The top level of the wrapper should be at the level of the ear, and that keeps the head in a nice neutral position and it avoids the head dropping down. There's loads of different types of wrappers. I think on some of the pictures you might have noticed what we used in Gambia was just a 2-meter stretch of material that the hospital tailor then made up into a specific wrapper. It's like a rectangle with 4 straps, very easy to tie. The mums can tie it and untie it themselves. But some places often just use like a 2-meter piece of material and wrap it around the baby. You also need to be careful not to have the nappy too high, because you're really limiting the amount of skin-to-skin contact that you get. And transferring babies, particularly if they're unstable, between the radiant heater and the incubator into kangaroo mother care position, they can have a little bit of instability during the transfer, but then once they are on the mother, that instability should settle. So who should be providing kangaroo mother care? So it's recommended, it really should be the mother, because you want to get all of those breastfeeding benefits. But we know that mothers often may not be available. During the EKMC trial, we really struggled within the first 24 hours after delivery for the mothers to be there. Often preterm low birth weight babies, the mums have had complicated pregnancies, complicated deliveries, maybe they're post C-section, maybe they're unwell with eclampsia or an infection. And so physically having the mother there to do kangaroo mother care was quite challenging initially. So in that situation, we really utilised the family support, which is absolutely critical. So other people can provide kangaroo mother care, including aunties, grandmothers, and about 50% of the first KMC in the EKMC trial was provided by aunties and grandmothers. And then when the mothers came, the mothers then took over. So this was some qualitative work that we did at the site in Gambia, where we did in-depth interviews with aunties and grandmothers of hospitalised preterm babies, really to understand what were their perceptions around kangaroo mother care and how willing were they to participate. And we identified that they were incredibly willing to both be surrogate KMC providers, but also to support the mother in other ways. For example, looking after children at home, doing domestic work, so the mother could be available in the hospital to provide the kangaroo mother care. Now, really important, as I've mentioned, is the duration of KMC. Minimum 8 hours per day for growth. We know that it's 6 hours per day, and each session should last for at least 1 hour. Really, that the evidence behind this comes from, you want the baby to complete a sleep-wake cycle while they're in skin-to-skin position. So we recommend at least 1 hour per day. You can see these are some of the mothers at the unit in Gambia. And providing it can be very challenging in a busy hospital setting. So this photo at the bottom was on the neonatal unit in the Gambia. And you can see we introduced beds, adult beds with mosquito nets, waterproof mattresses, etc., really to try and encourage continuous skin-to-skin contact. And even with all these measures, lots of education with the mums, lots of resources put into it, we still only achieved 6.7 hours per day on average. So things to think about is you need space to put these beds in. You need comfort levels for the mums. So these reclining chairs were really well received. And it needs to be respectful care. There can be a lot of barriers, in many different settings. I see this in Scotland all the time, that mums can feel very embarrassed about exposing themselves, about being partially dressed in a public space. So making sure you have privacy screens, that women have a place to change, a place to shower as well, is really important. And something which our women really complained about a lot was getting bored doing KMC. So we had things like a television with a DVD player and, different ways of trying to encourage the mothers to stay in hospital and provide continuous KMC. And making sure there was hygiene and wash facilities is also really important. So just a comment to think about the safety of KMC. It is safe, but you have to take some precautions. If you're using kangaroo mother care with unwell infants or neonates, you really need to be using a pulse oximeter. We did some other qualitative work with the healthcare providers at the site in Gambia, and they were very worried about IV fluids. So if a baby's on fluids and KMC, be careful with the wrapper. This fluid line can get obstructed, kinked, and it can cause problems with hypo or hyperglycemia. Need to use a pulse oximeter if the baby's also on oxygen or CPAP, and knowing how to securely position the baby using the wrapper and educate the mothers is so important. Thinking again about feeding, weight gain, growth with kangaroo mother care, as well as the low duration in the EKMC trial, I think another reason that we didn't show any weight gain effect was because it's not just about the kangaroo mother care. It's about the holistic environment for how these babies are fed. So often we use NG tube feeding a lot. but there wasn't initially a facility to safely store express breast milk. So what happened initially was each time these mums wanted to feed their baby, they had to take the baby out of KMC position, express, and then feed through the NG tube. So the baby is A, getting a lot less KMC time, and B, you're not really optimizing the nutrition of that baby. And thinking about, but then when we got a fridge and mums were able to store their express breast milk, we did see an improvement. Again, education of KMC providers. If you have human milk donor banks in your particular setting, then you know that is a good thing to use, especially during the first few days if mum's milk supply is not optimum. I'm aware I've gone completely over time, but I don't have many more slides left. So a critical part of Kangaroo Mother Care is that it continues after discharge from the hospital in the community, and having that continuity of KMC is really important. We used to send babies home at 1.1 kilos if they were doing Kangaroo Mother Care, and then they would come weekly to the follow-up clinic, and which was a nurse-led clinic, and would have ongoing education and regular follow-up until they were 2.5 kilos. So it is possible to do. We had about 80% return rates to the clinic, so we really had an engaged set of mothers. And then if these babies, if they go home at 1.1 kilos, they're at high risk of getting infections, becoming more unwell at home. And then if they need readmission to hospital, continuing that KMC in hospital, even if they're out with their neonatal period. Because the mechanisms that I talked about at the beginning, preventing hypothermia, optimizing glucose control, reducing stress, that applies just as well to a 2.1 kilo baby who is 2 months old as to a neonate. Just briefly about implementation, if you're thinking about setting up a Kangaroo Mother Care unit, so it took us about a year before EKMC trial onset. There's a lot of things to think about, but there is also some implementation guidance. This is what I used, which is quite old now, but there is more recent WHO implementation strategy, thinking about privacy, wrappers, education. And these were all the stakeholders that were involved in setup of Kangaroo Mother Care at the main unit in the Gambia. And you really need buy-in and training of the healthcare workers, which is a critical aspect. And we also got buy-in from the Ministry of Health, and there is now a national KMC implementation programme, which is ongoing, using a lot of the resources we developed for this. So to summarise, Kangaroo Mother Care is a family-centred package of care. It is literally life-saving and has a very strong evidence base. The mechanisms are worth thinking about and knowing, and they apply regardless of age. If you can have better thermal control, if you can prevent infections and promote breastfeeding using Kangaroo Mother Care, that will work whether a baby is 2 days or 22 days or 42 days. Use it in health facilities in the community using that 2.5 kilo cutoff. And really using Kangaroo Mother Care for babies 1 to 6 months old with malnutrition. I think it's a key evidence gap. It really could be utilised a lot more, and it's very encouraging. And I'd love to hear about Mammy's work in this area. So thank you very much. Here are some useful resources. That's the implementation strategy I was mentioning. And also Healthy Newborn Network has a lot of the recent publications and resources about Kangaroo Mother Care. Thank you.